all of you. This afternoon, I would like to share with you some thoughts on how you would manage the parturient with stenotic heart lesions for delivery. This is the hospital where I work in. It is the University Malaya Medical Center, where we deliver about 5,000 babies every year. This represents about 1% of the total number of deliveries we have in the country. We have about 500,000 or 500,000 of deliveries every year. We are actually a referral center, so in spite of the fact that we actually cover only 1% of the total country's delivery, we, being a referral center, will see quite a number of high-risk patients, and some of the high-risk patients have cardiac lesions, so we have quite a lot of experience in managing them. This afternoon, I propose to cover these topics: the importance of cardiac disease in obstetrics, why stenotic lesions have worse prognosis, and I'm going to try to risk categorize them and look at the level of care we should provide for them. Then we're going to talk about plans for these patients and how you would go about providing analgesia and anesthesia for them. And if we have the time, we may focus a little bit on managing their antithrombotic therapy, because a lot of them may be on this as well. Well, as you can see here, cardiac disease actually is the most important indirect cause for maternal mortality in the United Kingdom. And this is actually quite true for a lot of countries as well. And if you can look here, you will find that these are some of the factors that provide an adverse outcome. And one of the adverse factors is actually left heart obstruction. Patients with obstruction in the heart actually have about a 6 times increased odds ratio of dying. I know this is actually a very busy slide. You can't see anything very much, but I just want to bring your attention to the fact that over the years, in the United Kingdom, where they have kept a brilliant database, stenotic lesions actually feature quite prominently as well in all these causes of cardiac disease death in the United Kingdom. Now, why is it that these patients feature so prominently? Is because physiologically during pregnancy, there is increase in blood volume and increase in cardiac output, where stenotic lesion patients find it difficult to cope. And during the delivery itself, there's also concomitant increase in cardiac output and shifts in blood volume, where stenotic lesion patients again find it almost difficult to cope, and most of them go into heart failure. And if not managed properly, they actually will meet their demise. Now, so how should we approach these patients for analgesia and for cesarean section? A good way to start would be to risk categorize them. In 1997, this person by the name of Clark actually classified patients into 3 groups based on their mortality risk. And as you can see here, those patients with mitral stenosis in New York Heart classification 1 and 2 has got only a mortality rate of about less than 1%. So if you have this particular group of patients, because the mortality rate is not exceedingly high, you can actually manage them like in a normal hospital with fairly normal facilities. But when you come across stenotic lesions with these kind of lesions, that is mitral stenosis with atrial fibrillation, or mitral stenosis with higher New York Heart Association classification, aortic stenosis, or even coarctation of aorta, you should consider managing them in specialist hospitals, because these patients have got very much higher mortality rate of about 5 to 15%. And if you have a patient with complicated coarctation of aorta, where the mortality rate is exceedingly high of about 25 to 50%, you should not only have them managed in specialist hospital, there must be a specialist team that can cope with them as well. Now, as you can see, for the stenotic lesion, it is actually very important to know how severely stenosed these lesions are, because the more severe the stenosis, the more likely they have an adverse outcome. Now, if you're going to manage them properly, it is very important to gather your team, know the risk classification that the patient is actually in, and provide the correct level of care. So your team must be able to design or to kind of come to a conclusion, what kind of plans have to be put in place so that these patients can safely deliver. To start off with, we may have to consider, the team may have to consider obstetric and anesthetic plans. What exactly, especially for the anesthetic plans, if you are considering labor delivery, what kind of analgesia you want to provide, what kind of anesthesia if the patient is going for cesarean section, and what monitoring and post-op care you want to implement so that the patient can safely deliver. It is important that I reiterate that these patients should get the correct level of care. In fact, these patients are not for novices to manage. Now, you can see here that this is actually data from the International Journal of Obstetric Anesthesia in 2003, where actually these data have come from the UK Registry of High-Risk Obstetrics, where in 1996, Dr. Yentis actually got his team of providers in the United Kingdom to actually continue to provide data as they manage their high-risk patients. So this registry collected all the data, and initially they started off with cardiac as well as respiratory patients, and by about 2003, they were able to collect quite a number of interesting data of patients that were high risk, that were complicated, and it is actually from there that I've actually got some of the data on how to manage all these stenotic lesions. So I'm actually highlighting for you this particular category of patients with aortic stenosis, and as you can see, in a lot of these patients' management, anesthesia and analgesia as well as obstetric plans are initiated even before the delivery. And when you have these patients in the obstetric plan, you must not draw the conclusion that cesarean section is the order of the day. They should only have cesarean section if they have an obstetric indication. Otherwise, it's perfectly safe, and in fact, it is considered a norm to deliver vaginally as well. Now, while the obstetric plan is actually already deliberated, we also have to have our plans. And these plans are actually tailored according to the delivery needs, of course, so you must get your obstetrician to tell you how they want to deliver the mother, and you have to tailor the anesthetic plans according to the form of delivery, according to what the patient needs. But it is very important that whatever you design in terms of plans, you must actually plan it such that you maintain cardiovascular stability at all times. And this includes trying to maintain an adequate preload, making sure that the patient stays in sinus rhythm, protect against tachycardia, protect against bradycardia, avoid systemic hypotension, and avoid myocardial depression. So it's actually quite a tall order, but if you actually focus on all these elements, you will safely get the patient through as well. Now, over here, we have actually the analgesia again for these patients. As you can see, epidural seems to be the preferred method of analgesia for these patients who had aortic stenosis. It was planned and it was actually delivered as well. Now, the important thing to actually note is it was a planned admission, they had invasive monitoring, they had epidural, and they also assisted the delivery so that the mother didn't have to do the hard work of pushing. Because if the mother increased her work of delivery, she will actually need to have increased pump activity, and that will stress the heart. And of course, in order to maintain hemodynamic stability, they were using low dose and they were titrating their drugs. Of course, besides epidural, you can also use continuous spinal analgesia. Again, the important emphasis is hemodynamic stability, and they were using drugs like sulfentanyl and ropivacaine. Now, what about anesthesia for cesarean section? Is it better to have a general anesthesia? Is it better to have a regional anesthesia? All sorts of regional anesthesia and of course general anesthesia has all been described for these category of stenotic lesion patients. But the most important thing to actually focus on is the fact that whatever you choose, make sure that the drugs are fractionated, titrated. Now, it is okay if you're using epidural and continuous spinal because you can actually fractionate and titrate your drugs. However, if you're using a single short spinal, it is not titratable and you can't fractionate your drugs. So we would advise that you do not use single shot spinal. Now, for the general anesthesia itself, we have what is described as a high-dose narcotic cardiac type of anesthesia, which I'll be elaborating in a short while. So you can see here, when you had anesthesia, this was what was administered for this category of patient. In the output that came out from the International Journal of Obstetric Anesthesia in 2003, you will find that there was a predominance of general anesthesia for these patients. In fact, around that period of time, a lot of providers felt that general anesthesia was actually safer because they could actually have better control of the situation. But since then, we've actually seen quite a lot of literature moving away, all right? But just to tell you what general anesthesia for this category of patients is actually like, most of the time for us, when we are providing general anesthesia for the usual patient, we give the narcotic after the delivery of the baby. But in the patient with stenotic lesion, especially aortic stenosis, when you're providing the general anesthesia, you may actually consider to maintain hemodynamic stability, you may actually consider giving the narcotics before the delivery of the baby. But of course, you have to tell the pediatrician that the narcotics has been given, and they can usually manage quite well the narcotic. Now, remifentanil is a very short-acting drug, and so it's actually advocated for those of you who actually have the drug. And this is one of the case report that has come through where they were using quite cardiac stabilizing drugs like etomidate, and of course remifentanil as well. Now, earlier on I was saying that general anesthesia was kind of advocated previously, but in the last 10 years or so, we've actually seen that regional anesthesia, carefully titrated, carefully fractionated, is actually equally safe for this category of patients. And of course, just to reiterate, it is very important to understand that single shot spinal is not for this category of patient because you can't maintain hemodynamic stability with this technique. Now, safety actually lies in attention to details. So earlier on, I did emphasize that we have to titrate the drugs. Now, even the oxytocics that we administer after the baby is delivered should also be titrated. As you can see, when you give your oxytocic agent, especially, even with small doses like 5 units, which we are now administering, they actually also develop tachycardia, which is actually not which can compromise hemodynamic stability. So those of us who actually look after these patients, we may even fractionate the 5 units of oxytocin in this to reduce the incidence of tachycardia, which can compromise cardiac output. Now, what do we do with monitoring of these patients during delivery as well as post-op? Well, the monitoring depends on what has been administered, whether it's for analgesia or anesthesia. It depends on the lesion, the degree of compromise in the lesion. It depends on the functional class. And of course, we don't want our monitoring to actually cause risk to the mother as well. So all these have to be taken into consideration when we organize our monitoring. Now, in that set of patients again, where there were actually 24 cases of aortic stenosis, 15 of the patients actually delivered vaginally. And out of these 15, 11 had a non-invasive blood pressure monitor, 4 had an invasive blood pressure monitor, and there were no CVP done on this particular group of patients. 9 had cesarean section, and as you can see, 3 had just invasive blood pressure, ECG, and a pulse oximeter. 5 needed invasive blood pressure monitoring, ECG, pulse oximeter, and the CVP. And 1 actually had, in addition to all the above, had esophageal echocardiography to monitor. I'm not sure how they did it, but they actually needed this particular mode of monitoring. Now, what do we do with them for post-delivery care? Again, those with poor prognosis needs ICU care, and those with higher New York Heart Association classification deserves ICU care as well. One must also think of good pain relief because stress actually pain would stress the cardiovascular system, and it may determine the outcome of the patient, especially if pain causes tachycardia, the patient may decompensate, the patient may go into heart failure and be very compromised. So again, out of those 24 cases, 4 patients were had elective transfer to the intensive care. They stayed for a period of 1 to 7 days. 1 patient had been booked for ICU, but they subsequently stayed in a delivery suite. And 19 actually stayed in the delivery or the labor ward area where they had HDU facilities. Now, since I had time, I would like to actually focus a little bit on this antithrombotic agents that a lot of these patients may actually be on. Now, you'll find that some of these patients may be on the oral anticoagulants, some will be on heparin. But I just would like to tell you that where the mother is concerned, it is actually more important, if you want to prevent thrombosis, for the mother to be on the oral anticoagulants, because their risk is actually very much lower if they are on oral anticoagulants, and it is actually higher if they are on heparin drugs. Where the baby is concerned, there has been a lot of anxiety about the use of oral anticoagulants because the embryopathy risk is higher compared to if they were on heparin. So you can see that the interest of the mother and the interest of the baby do conflict with each other when you want to actually consider antithrombotic agents for the mother. So what exactly usually happens is there's a compromise in the sense that during the organ genesis period of 4th to the 8th week of pregnancy, the mother is usually on heparin for the first trimester, and then for better coverage, the mother is on warfarin, and by the time the mother comes to term at 36 weeks, she's converted back to heparin so that we have an easier manipulation of the antithrombosis so that you can actually sort out your anesthesia, especially regional anesthesia, if you need it. Now, this has actually already been highlighted by Dr. Anjam, but it is very important to actually consider, because sometimes you can still be caught with the mother before the 36 weeks. So if the mother is actually planned for delivery but still on heparin, you might want to consider for analgesia, patient-controlled analgesia. But for cesarean section, of course, there's no choice but to use general anesthesia if you have a situation where you are actually on warfarin. But if you have patients on heparin, of course, you can organize the appropriate timing and provide the regional anesthesia if it is possible. While we actually have plans for patients and we get ourselves organized, there are patients sometimes who actually pass through all this network of plans, and they can actually provide they can provide a lot of challenges for us during the emergency period. In fact, I must actually share with you this particular patient who was actually an unbooked primigravida with very severe mitral stenosis. We were alerted that she was actually coming. We got the theatre ready. By the time we saw her, she was cyanosed, she was frothing, she was bradycardic. And what did we do? We gave her the cardiac type of anesthesia, where we actually gave her a high dose of fentanyl because remifentanil was not available to us at that time. We gave thiopentone, reduced dose, and then we actually intubated her with Sux, and we realized that we must limit the fluids because of the immense fluid shifts she was already experiencing. We just monitored her with a non-invasive blood pressure monitor, and she had just ECG monitor as well. The good news was she survived the anesthesia and the delivery, and she was actually admitted into ICU for further care, and she was, of course, discharged quite safely. So in summary, I would like to reinforce that cardiac parturients do feature predominantly in maternal death, and stenotic lesions have very bad prognosis. So you must organize your obstetric and anesthetic plans, and safe anesthesia and analgesia should match the physiological changes with proper technique, and you must maintain hemodynamic stability. With that, I would like to thank you for your kind attention.